Good afternoon, everyone. Thank you for joining us for this final webinar of IMI's Big Data at Heart. My name is Dwayne Schultes. I'll be moderating the webinar today. And where we're going to be presenting is the final results of the project. Our speakers will provide a comprehensive overview of the project results, as well as its potential future applications. And I'm very pleased to be joined by three of the project leaders. Firstly, I'd like to introduce Rick Groba, who's professor of clinical epidemiology at the University Medical Center Utrecht. Hello, Rick. How are you doing, sir?
Fine, thank you, Dwayne.
And I'd also like to have with us and introduce Volkert Alsenbergs, professor of precision medicine at Amsterdam University Medical Center and the University College London. Hello, Volkert. How are you, sir?
Hi, sorry.
Good to see you, sir. And finally, we have Alicia Eil, who's the assistant professor in cardiovascular epidemiology and University Medical Center Utrecht. Hello, Alicia. How are you?
Hi, I'm well. Thank you.
Thank you all for joining us, and thank you. We look forward to your presentations. If any of you have any questions, please use the little Q&A button at the bottom of your menu. We will then filter these out to the panelists. We look forward to your interaction. And with that, I now pass the floor to Rick. Rick, presentation's yours. Thank you.
Thank you, Dwayne. I hope my screen is visible now.
It looks great, Rick. Good to go.
So much. Well, it's a great pleasure really to be here today and inform the audience online, getting online. I see people entering every second, but also subsequently when we will put this this webinar on several places on the internet for people to see what Big Data at Heart intended to do, but even more importantly, what it has done and what it will mean in the future. So I have the pleasure to give a brief introduction as one of the members of the leadership, and my colleagues will take it from there. To go back to its origins, about six years ago, when we set out with a large consortium with the goal to deliver clinically relevant disease phenotypes, scalable insights from real-world evidence and insights driving drug development and personalized medicine. And all of this, of course, using advanced analytics that in the meantime have become probably more mainstream than they were at that point in time. This hasn't changed entirely, that drug development processes have challenges like poor definitions of diseases, which therefore generate heterogeneity in mechanisms and also the frequent occurrence of comorbidities. Patient-centered outcomes are important, but there's very few that are accepted and approved. Data access is limited to selected small patient populations, and there's a clear need to get a better insight in what happens in the real world. Trying to extrapolate from trials to the real world is sometimes difficult because of large inter-individual variation in prognosis and subsequently difference in heterogeneity in patient responses. So in order to get closer to solutions here, we set out to address some of the challenges, better understanding of disease etiology and prognosis, drawing from unselected patient populations across the EU, thereby also being able to subphenotype diseases where, in addition to the phenotype itself, also comorbidities and underlying mechanisms could be addressed. In passing, also with relevant stakeholders like patient organization, obtain patient-relevant outcomes that could be employed in day-to-day research, leading hopefully to more standardized operational disease and outcome definitions, and Alicia and Volker will speak on that, thereby supporting improved trial design and eventually getting drugs to market quicker, but also more targeted to the right patient populations, hopefully leading to an improved response to treatment, which currently in cardiovascular disease is still quite suboptimal. Now, we were in a very fortunate circumstance in the Big Data at Heart consortium to have a number of major assets. One, the consortium itself, you see here logos of partners that were part of the consortium and are still working on its products. Really unparalleled array, very transdisciplinary, stakeholders from various sides, including patients, regulators, academia, and pharma companies. And all of them have been really instrumental in leading to the successes and the deliverables of BigData Heart. And the second asset, perhaps even more important, is access to a large number of big data sets. BigData Heart is about big data sets, large scale, but also with a lot of phenotypic information, ranging from clinical characteristics all the way to omics in various forms and fashions that formed the basis from which we could draw our empirical analyses. The resources asset, a consortium, very responsive, still responsive after 6 years, including COVID hitting us, still very responsive and agile. And we'll speak briefly about the future in which many of these will hopefully stay involved. And we found many channels for proper and wide dissemination. And I should not forget to also specifically mention the role that the European Society of Cardiology has taken in that latter aspects, helping us reaching out to the broader professional and lay community. For those not intimately involved in BigData Heart, this is the architecture, if you wish. We had a number of work packages, one on outcome definitions, one on the data harmonization, very important, data enrichment, as said, adding additional information to data sets, data analyses, utilizing state-of-the-art data analytic and data scientific techniques. Obviously, in a cross-country project involving large numbers of data, ethics, legal, and privacy aspects were important as addressed in Work Package 7. And all of this had to be managed and had to be communicated, for which we had 2 separate work packages. To be sure that we were benefiting from competences in these various work packages to the maximum, we defined 6 cross-cutting pilot studies on which Volkert and Alicia will report to you in a moment. These are the case studies. I'll not run through all of these, but they range from real-world comparisons of heart failure patients and comparisons of heart failure patients to trial populations to see whether they are different or perhaps even similar in some aspects, all the way to examining how wearables can be used, also to perhaps bring us closer to measures that are relevant and can be obtained from patients on a day-to-day basis. Now, in a moment, you'll see what BigData Heart has produced so far, and you're invited to also raise questions about some of these learnings. But now that we're facing the end of the formal study period or project period financed by the EU, we are entering to a sustainability phase that we're currently thinking about and working on with many of those involved in the consortium. Here you see some of the main databases, data sources across countries that we have been able to use, and we have been showing that we can bring together this sort of evidence, and it really has developed into a network, an ecosystem, formalizing some of the objectives of BigData Heart and providing unique opportunities for the future. And in that regard, the intent of the BigData Heart consortium is to create a sustainable platform where public and private parties can address questions about the real-world use of drugs in various cardiovascular diseases or syndromes. That's work in progress. We've just been starting this activity, and of course have been preparing for that while we were finishing BigData Heart. And one of the preparations in that regard is a case study that we are currently running, and Alicia is very much involved in that, but many others are too, where we try to demonstrate the power of a federated learning approach, that circumvenes some of the data regulation complications otherwise encountered. And in this case, to study medication prescription and outcomes in hospitalized heart failure patients with CKD. It's an interesting clinical question, and we believe that by doing this by rolling out a study, benefiting from all that we've been able to assemble and learn in Big Data at Heart, that we can demonstrate that addressing these sorts of questions is something that Big Data at Heart can do in the future based on its sustainability plans. Now, in this particular case study from the large data community of Big Data at Heart, we have selected 9 hospitals that are particularly well suited to test out the methodology across 6 European countries, giving it a real international dimension. And as I indicated previously in one of the slides, the methods we're using here is federation, where the data stay in the hospitals, which we can nonetheless learn from these data as if it were one big cohort study of patients with heart failure and CKD. I think by way of introduction, Wayne, this should suffice. Is it okay? I'd be pleased to address questions later on, but maybe now Volker can continue.
That's great, Rick. Thank you very much. That gives us a very good overview from the top line, and it's much obliged. So I'm now going to pass the floor to Volker Alsenbergs, who's going to talk about some of the specifics on the deliverables and the objectives of the project and how they were manifested. Volker, the floor is yours. Thank you, sir.
Great. Thanks, Dwayne. So thanks for the introduction. It's really a pleasure to introduce some of the highlights of the Big Data at Heart. It's quite accomplishments we've made in the last 6 years, as Rick already highlighted. And so it's a bit superficial overview, but it's just Dwayne promised me to put it online, the webinar after, because we are recording it. So don't write down the references. You probably can catch them up later on. So I'll just briefly overview one of the major accomplishments of the Big Data at Heart consortium for the past 6 years. As Rick already showed, right, we have several objectives focusing on clinically relevant disease phenotypes, real-world evidence, drug development, and personalized medicine. And I will just go through them a bit and give some exemplars of how we address these objectives in the last years. So to start off with the clinical relevant disease phenotypes, underpinning research and innovation. Of course, first of all, is how do we standardize disease definitions so that we ensure that we don't compare apples to oranges. And of course, with big data and also with AI and novel methods to discover new phenotypes that are not feasible so far, because it was all descriptive predominantly in healthcare. And I think big data and electronic health records give us the opportunity to really reinvent medicine and how do we stratify patients at risk. But to start off with the definition of clinical outcomes and disease definitions, I think Big Data at Heart accomplished quite a lot. So together with our partner ICHOM within Data at Heart, we developed several papers in defining atrial fibrillation and heart failure, and to have a computable way of defining disease and outcome. And I think this is really crucial, right, for setting up clinical trials, for setting up observational real-world evidence, is we have to standardize and harmonize our definition. And it's not simply an ICD code, but it's a combination of factors that determines a certain definition. And we have to have universal consensus regarding this. And I think these are the first steps. But thanks to our partner, the European Society of Cardiology, but also with Deepak Kotecha from Birmingham, we're now piloting within the EC how we can also compute guidelines, right? For example, the guidelines are still analog. So how do we scale these guidelines and build them within your electronic health record system? We need a clear definition. And I think the EC is willing to pilot it and to experiment. And I think with AF, we will probably see the first results of this endeavor. And that's really by the work done in Big Data at Heart. So I think that's a really great accomplishment. Another thing is a bit of in line what I just discussed is we have, as a community at large, we have to set some rules if we want to use big data for clinical care. And that's done in this specific work package 2. There was a guideline developed, and Alicia will go in more detail, but I think I just want to emphasize, and this is really with a broad community of stakeholders, editors, regulatory agencies, for industry, research and clinicians, we developed this this checklist, and I think it is a great step, and I think a lot of editors adopted it already, and they're really trying to nudge people to make use of it. As Rick already mentioned, with the last use case that we had is, of course, big data at heart was really limited by the data sharing that we have now. I think Dwayne will ask a lot of questions about GDPR, but I think one of the potential solutions that we might have is the federated learning. So instead of trying to put all the data together into one big data lake, is then bring the code to the data in a distributed fashion. And I think, and it sounds nice, it sounds easy, but I think the hard work is, of course, the pre-processing of the data. And that's what Spears the Nexus has done in his team, is to OMOP, to harmonize the data models right within the different database, so that you can easily collaborate across different institutes, across different cohorts. And then on top of, you can build a distributed data analysis. And I think that's where we move beyond big data at heart, but the groundwork using the harmonization of data models by Spears and others, I think is instrumental. And I think big data at heart has really drive this field as well. Again, I think we're building new cohorts, we're trying to reinvent the wheel. I think one of the achievements is with big data at heart is to build a database, what's out there already, so that we don't make sure that we don't build new things, but make sure we use existing resources. We use national registries, we use electronic health records that are out there. So we try to map this, and that has been published Rachel last year in the cardiology, and it's also on the EEC website. So if you go to ec.org/bigdata, you can find all the resources that we provided within Big Data at Heart. And then what I mentioned, so first of all, is to standardize and harmonize, standardize the division that we have so far, but I think big data has really the opportunity to redefine disease. So instead of just having a description, like a medieval definition of a certain disease with a mixed bag of diagnosis, just what a doctor sees in front of them in combination with whatever, an echo and MRI, we can really use big data to redefine disease and have a novel taxonomy. And I think a lot of work has been done by Alicia, but also by others in this consortium, and that will really we'll see, I think, the guidelines in the next round, but also that will guide new trial designs, this new clustering of phenotypes. So I think this is really a major step forward. So if we go to the second objective, it's regarding real-world evidence, the clinical and the pharmaco epi. Again, for clinical trials, big data, you can really reuse existing data to populate your electronic CRF, and I think a lot of work is done. But also we have to get smarter about disease definition, which I just mentioned, but also the outcome. So there are several case studies, big data at heart, looking at more like digital biomarkers, for example, using a smartphone to detect atrial fibrillation, using PPG signals. But also there's from Stefan Anker a trial that they use wearables as an outcome for activity measures, for example. And as I just mentioned, we just need the disease definitions as well standardized, so we can use them for inclusion in trials. Of course, then you are able to really search your electronic health record system, as shown by Rick in a previous paper, and recruit patients at a faster pace, but also looking for whether it's even feasible in certain centers, right? And if you can map your inclusion-exclusion criteria on your electronic health record, that whole pipeline will be much more efficient. So this is the work done by Yvonne Lim. I think she's on the call as well. And she really compared the clinical trial that were available on Big Data at Heart with the record sheet, see whether they're actually generalizable. And I think there's a lot of lessons learned, how you can really design your trial in the best way to make sure that it really impacts the real-world patients, or even, or at least registry-based patients. So this is a great paper. You have the reference here, and you can always look it up, otherwise in the recorded webinar. As mentioned, I think wearable sensors will be, digital biomarkers will be increasingly used. And that's, of course, the wearables for like AF or heart rate, but also I think like patient-reported outcomes will be more and more important in future trials. And I think with app-based questionnaires, people can really implement this into their clinical trial. design. And I think with COVID, I think that accelerated indeed also remote recruitment of patients, e-consent, and follow-up visits virtually instead of people coming into the hospital or institute. So I think there's COVID-19 really accelerated the whole trial design on a virtual basis. This I just mentioned. This is done by Charité, and they really look into using the Apple Watch as an outcome parameter in this ongoing trial, FAIR HF2. Here in work package 5, it's regarding the pharmacoepi. A lot of stuff has been done by IMI Banerjee. He published last year. It's really interesting to look at, okay, how many patients with heart failure have recognized risk factors and whether they're amendable. You can see clearly there's a lot of prevention potential in heart failure patients, and always highlights as well, and I think that's what I just mentioned regarding the clustering, that heart failure by itself is not a single condition. There's multimorbidity that coexist with other diseases. And I think the question is what determines prognosis, the heart failure itself or the multimorbidities that we should target. And I think that's nicely shown in these type of data. And therefore, you really need big data and linked research to address this type of questions. Also, we looked at comparison between the heart failure epidemiology. Alicia looked into this across countries. And what we learned is especially that we need to harmonize, right? That it's really hard to compare this type of results because it really depends on the design, the structure of registries, and the ICD code itself is not universal enough to really just compare one-to-one. So I think we learned quite a lot from Big Data at Heart, how we can compare across institutes and across countries. Important for big data and real evidence, I think there's a lot of news as well, is of course you need patient engagement and public trust. And with the European Heart Network and with the people from the UMC Utrecht, from the ethical department, right? We've done quite a lot on the social license and sharing health data. And I think this really has to be taken into account into the design, and it can guide also policymakers in the European Union. So I think this is really important work, and it really has I think informed policymakers at large scale. Finally, the last objective was deliver advanced analytics through drug development and personalized medicine. So what we've done, we enriched several cohorts. We used proteomics, for example, the BioShift study from Erasmus, Isabella Cardis, just to see, instead of clustering only on existing data, electronic health record data, we try to do the same with proteomics, and you clearly see that heart failure is a mixed bag of diagnosis. Also, if you're using proteomics and identified novel targets for potential drugs, but also for novel biomarkers in this type of patients. So I think that's quite, this is done with SomaLogic, another partner within Big Data at Heart, and this is quite a substantial work. Another work with Tom Lambers, the Hermes Consortium, again, right, is looking how can we use genetics and how do we see what a genetic architecture of patients with heart failure, how they differ across the different clusters and types of heart failure. How am I doing, Dwayne? Are you tapping if you're...
I'm not tapping. Very interesting. All fine. Keep going, please. All good.
Fine. So another in work package 5 is how do we prioritize novel therapeutic targets? So it was not only on big data and electronic health records. We actually have developed like open source software, which are mentioned here as well. So how you can, for loss of function, how you can identify loss of function variants for druggable genome analysis to really find novel drug targets in complex diseases. So I think this is really important work as well, that you use genetics for identifying underlying mechanism, but also really to mimic clinical trials. And I think that's really powerful, is how you can use big data to guide your drug development, but also your clinical trial design. I think a lot of work has been done by people, Big Data Heart, in this aspect. This is another example done by Florian Schmidt, but also by the Cambridge people, looking at minimization and really developed pipelines for drug target validation. That's, I think, a really powerful tool for the industry partners within our consortium, but also for repurposing of medication. I think I won't go into detail, but just look up the papers. It's really powerful. There's some open source software as well that you can really use to just prioritize your drug pipeline if you're an industry company. So dissemination of results, I think that's what we're doing today as well. So thanks to Dwayne and his group, right? A lot of stuff has been done. Webinars, we have tried to also inform policymakers, as I just mentioned, which is less visible, which is really important. We had patient-facing events. Of course, we had newsletters, we had the website, but I think the webinars are a great tool to inform people. We also had great support from the European Society of Cardiology with these digital health platforms that we were able to really to communicate our results of Big Data at Heart. So thanks to our partners, and there have been more than 100 publications so far since the start of the project, but I think that will trickle down to more as we go on. And I think we cannot underestimate the impact of Big Data at Heart, because I think it really guided several initiatives, and I think there are already follow-up grants and follow-up initiatives based on the Big Data at Heart work. So I'm really proud to be part of this initiative. And of course, yeah, you can see everything on the Big Data at Heart website, but also, as I said, eccardio.org/bigdata. All the outputs of Big Data at Heart are there as well, including interviews and everything. And I will hand back to Dwayne.
Thank you very much, Volker. It's a tremendous amount of output in a very short period of time. It's quite incredible. I think I have a bunch of questions I would ask, and I'm sure other people do too. However, it would be very interesting to get some specifics here. And Alicia, I understand that you're going to be walking through a few of the key case studies, giving us a slightly more long-form explanation of some of the deliverables, and that would be great. The floor is yours. Thank you very much.
Thank you so much. Let me share my screen. Thank you so much for having the opportunity to speak here today. And indeed, I will go into a few of the different papers that have been published during the time from Big Data at Heart. I picked out 3 of them, but obviously if there's questions about anything else, please put them in the question box. But today I wanted to go a bit more in depth in the CODE-EHR framework, into phenotyping heart failure, and into guiding future trials with case study 1. So first up, CODE-EHR, which was a framework that was developed in collaboration with all the different stakeholders from Big Data at Heart. And it's really a checklist designed to make better use of electronic health records for real-world research. So I wanted to give you a bit more of an insight into how this came about. So if we start from our electronic health records in the middle, there's a few different key challenges that are associated with this, which is especially when you want to compare within countries or between countries, there's a lot of different variety in the data. And there's several solutions or paths for improvement that could help in this. And first of all, it's obviously to identify the different data sources, which is also something that Big Data at Heart has put effort into, but also showing who is doing the coding, what coding systems are being used, and what the purposes of this. So when we look a bit more into that coded data, there's still more key challenges to be identified, which is the quality of coding or the different algorithms that are being used and could not be comparable with each other. So a path for improvement here could be that it's better to publish your code list, publish phenotype algorithms, and for example, HDR UK has a fantastic phenotype algorithm library online that can be used to on electronic health records to have more of a harmonization. So when we look into disease outcomes and definitions, there's also ideas about privacy and consent and the transparency of the data sources. So here it's very important to publish the completeness of follow-up and also to describe how missing data was handled and what was being done with it. And also, of course, the linkage of the data sets. When we look into the research and publications, there could be a lack of transparency or uncertainty about the quality of the data. So it's very important to assess all the data for consistency, for completeness, and for accuracy. And of course, when we look into the regulatory and guidelines, what this framework could impact is that there's more confidence in the results that are being presented. And these EHR coded studies can be better incorporated in regulatory decisions if there's a better framework to assess them. Also linked to the CODE-EHR framework is that positive roadmap for patient and public involvement. If patients and public are more involved in ongoing research, then it's more of a two-way communication and active participation of these patients into what kind of results and what the transparency of the results can mean. So this is what the framework looks like. There's a few different items on the list that are being put into standards. So for each of these components, so data construction and linkage, fit for purpose, definitions, analysis, etc., there is a framework standard that's being advised. There's a minimum standard and there's a preferred standard, and the framework shows exactly how these work. So please go on the website to find more detailed information about this. Going on to the second part of the presentation is phenotyping heart failure, which is something very near to my heart because this is also something that I do on my daily life as a researcher. So I want to go a bit more in detail in heart failure, and then specifically heart failure that preserve ejection fraction. So these are patients with an ejection fraction of about 50%. And a lot of the clinical trials that have been done have shown neutral results. And this makes us wonder, why is that the case? Is it because the wrong outcome was included? Is it because the wrong treatment was selected? Or was it because of the wrong patient was included? Well, luckily for us, there's now a few more recent studies that have shown that there are some subgroup analyses that show benefit in these patients with spironolactone and sacubitril valsartan, and of course the very successful SGLT2 inhibitor trials. But still, we think that we could do something different, and we could do something with these patients, and there could be patients that have maybe more benefits compared to other patients. And therefore, it could be possible that a phenotype approach is more wanted in heart failure. Currently, if we look at cancer, for example, there's a judged targeted therapy based on biopsy, imaging, phenotypic analysis, and then a targeted therapy is selected. But for heart failure, what do? We look at ejection fraction and we look at functional class, and then we give the patient the same treatment, all of them. So I think there could be some changes being made into this. So this is what's being done, not only by us or by other people in the consortium, but across the world, looking into phenotyping heart failure. So this is making use of clustering techniques to classify heart failure patients based on clinical characteristics. And what we found, this is a study that we've done in the Swedish Heart Failure Registry, where we actually saw that there's 5 different clusters of patients with preserved ejection fraction. We could identify patients that were younger. We could identify patients that have more often atrial fibrillation and hypertension. There was also a large group of patients that were elderly, more often female, more often had atrial fibrillation. And also a group of patients that were more clustered around the metabolic syndrome, so patients with obesity and diabetes. And lastly, we found a cardiorenal cluster, which we identified as patients being older and more often having lower kidney function. So what we also saw in these patients, that there's differences in survival. So we see that the younger cluster, for example, had a much better survival than the elderly or the cardiorenal cluster. So these are really important findings, but have not led to a phenotypical approach just yet. So we still have some more work to do even after Big Data Heart. I did want to highlight one of the very interesting papers that was done in patients with reduced ejection fraction about redefining the beta blocker response in these patients, which was from the Beta Blocker Collaborative. And they actually showed that they could make clusters based on patients that were in sinus rhythm, and they showed that there was a very similar response across the clusters. But if they looked specifically into the patients with atrial fibrillation, there appeared to be one cluster that showed a different treatment response in response to the beta blockers. So this is very, very interesting information published in the Lancet, and I please reference you to the paper to look it up, because it's very informative and very interesting to see how these kinds of results could then also change the way that we do clinical trials. And speaking of clinical trials, we're going on to the last part of this presentation, which is about case study 1, which is about guiding clinical trials. So case study 1 was to compare the real-world heart failure patients to trial patients. And this is because there's a little bit of a gap in generalizability of study results. Patients in clinical trials, they're different from the patients that are seen in daily practice. So this study really wants to evaluate what are these differences and what do we see. So when harmonized eligibility criteria were applied, so these are the ones from the trials, so these are from the pharma partners that were included in BigData Heart, we actually saw that patients in registries, about 56% of the patients would be eligible to participate in these trials. However, there were still some differences beyond the eligibility criteria if you look at the differences in the patient population. So on the trial, this would be more men and a bit of a higher ejection fraction, whereas in the registry, there were more older and more women included, and also more patients with non-cardiac comorbidities. So delving a bit deeper into the results of the study, the all-cause mortality and cardiovascular mortality were compared between the registry, the patients that were eligible and non-eligible, and then the trial. And what we saw is that when we actually standardized the mortality ratios, we saw that age and sex mainly explained most of the mortality difference between the different groups. So therefore, there's still a higher cardiovascular mortality risk in the patients that were in the trials compared to the trial eligible patients in the registry. So this really shows that in contemporary registries, a lot of the patients would have been eligible for trial enrollment. And based on the case mix, trial participants had a similar rate of survival as those in the registries, but still had a higher cardiovascular mortality rate. So these are all very interesting findings that could be later on applied to guide future clinical trials. Thank you so much for your attention. I'll give the floor back to Dwayne.
Thank you very much, Alicia, and thank you, all of you. I'd like to open up the floor to folks in the audience. Again, if you have a question for our panelists about the results, please feel free to use the Q&A menu button. We have 30 of you online. Please feel free to submit your questions, and I'll filter those through to the panelists. We're talking a lot, and what's amazing here is that you've managed to develop a lot of really unique analysis using these federated databases. And one of the challenges we've seen with IMI programs has been taking some of the results that we find and then putting them practically into clinical practice. So if, Rick, if we think about, your work, you're an epidemiologist, but you're also a CRO. We see a lot of regulatory divergence now and not a lot of convergence with the use of data in large data sets and real world evidence. Do you think a program like BigData Heart can sort of start bringing the regulatory divergence to convergence? Can we start finding mechanisms to make things work more in unison?
Well, we still have to see whether that works out, but for sure, there has been a demand by society, and that is reflected in the position that regulators and each HTA bodies may take, a tendency to ask for drugs that work better in individual patients. And the approach, as Alicia showed, for example, for heart failure until recently, has very much been a one-size-fits-all, and consequently an average effect that means some people will benefit, others will not. And in fact, for many drugs that we use in cardiology or cardiovascular medicine, there's a fair proportion of patients that shows no response, but will experience the side effects of that. Much of that is typically hidden in trials with highly selected populations, and something that for the real world in clinical practice is of obvious relevance. So studies like Alicia showed on beta blockers, but also some of the heart failure phenotype differences reflecting mechanisms will allow us to address drugs that are much more specific because they fit the phenotype and the mechanism better. And again, that's something that also regulators ask for, and there's a clear opportunity to provide such a diversified approach. And on the side of payers, as sort of an echo of value-based medicine, there's also a need to see that drugs do their work well, and even a tendency. And there was an example in one slide on cancer. We're not quite that far in cardiology yet, but in cancer, there's now treatments where the producers only paid for when the drug works.
Yeah, absolutely. Some of the CAR T therapeutics in particular, that's what we've seen. Volker, you mentioned pilots, and there's often a criticism that we get pilotitis. And Alicia, you're talking about some practical applications. So the question for both of you, how do you see transferring what you've done within the context of IMI into actual clinical practice? How do you actually get this into functional top-line work you deal with every day to solve patient problems? I don't care, either of you, please.
Can I kick off? Otherwise, I just mentioned in the presentation as well. So I think that's the nice thing about the IMI and consortia is that it's quite interdisciplinary, and there is quite big range of partners. So we had industry partners, but we also had like European Society of Cardiology as a partner. And I think if you really want to impact, you need to have the healthcare professionals, right, on board, right? So and there's a difference between research, right, and the clinicians, right, actually on the bedside. And I think the European Society can really bridge that gap, and they've done it, right? So they're actually now looking for computable guidelines, for example. So the work that we've done, how do you compute it within guidelines so that it can really be adopted and goes beyond the simple pilot study, right, within a research frame, impact clinical healthcare.
And go ahead. And Alicia, from your perspective, how do you see this working?
No, I completely agree with Volker, and I also think it's very important that we can validate our results in different data sources. So these results that we show here, they need to be shown also in other settings, and that will really help with the implementation of these kinds of models that we're making.
And in order to do so, you need to have the practical application of real-world evidence in multiple data sets across multiple jurisdictions. For example, the international standard outcomes measures that you're talking about, as well as the ability to do federated data analysis. How should, in your opinion, Alicia, the EU promote the adoption of the CODE-EHR checklist that you discussed? How are you going to try and make sure that this is being adopted, maybe from some people who don't want to? How do you get that to happen?
I think it would be really nice if the editors of different journals can make sure that these kinds of guidelines are being checked. So the same with the grade checklist for systematic reviews. It would be really nice if people are doing research with electronic health records, that they need to fill in this checklist to show exactly what their research is and how that fits, and what the standard is of the studies.
Volker, from your perspective, do you think the cardiological profession will be interested in trying to change horses in the middle of the stream? It's often a profession that's known for some level of intransience, with all due respect. How do we make sure that people start adopting these changes?
It's a bit of the carrot and stick, right? So it's just, I think the editors, so what we've done, so we built this CODE-EHR, but what we've done is now we emailed all the editors, all major journals, and they're quite receptive to it. So if you look at instruction of authors, while it has been published, I think only a few months ago, it's already an instruction of authors, right? So I think it's a small nudge, right, that people do. And of course, and if the large trials, etc., will really adopt it, this kind of CODE-EHR, then it will come by itself. Of course, we have to be critical that it's just not a checklist, right?
Yeah.
It's not often checklists are, people have their paper ready and then they, oh shoot, let's get the checklist and then see whether they can and put something in the supplemental file. What we try to achieve with CODE-EHR, that people really use it for their design, right? So not at the end for the report, right? Because that's just, right, that's just administratively workload. But really think about it beforehand. How do you actually do a proper real-world evidence trial or study?
So the carrot then would be funding for trials. The stick would be regulation. Rick, what do you think? Do you think there needs to be a combination of putting this into clinical practice for clinical trial work and research work? Do you think there needs to be some combination of regulatory background to put this in place? What do you reckon on that? Oops, you're muted, sir. You're muted.
This beginner's error. Sorry about it. Anyway, yeah. Well, what Volker and Alicia just said is important, that editors are going to ask for it, but it's not enough. Indeed, it needs to be something that's part of a culture, and it needs to be in the back of the minds of people once they design studies. So just like currently, when the EU provides funding, it asks in the proposal a very detailed account on, for example, how fair data are. That's one example. So it's something you need to be built into your study. It's something that needs to be there by design. So in that sense, the CODE-EHR is not a checklist per se. It's a system that you can utilize to improve your work early on, so there's no surprises towards the end. And I think that's going to work. It may be modified. We propose this, of course, without too much of an empirical learning and how it would develop, and it may be modified. But I think it's an important start, and it will, for sure, will improve the work, and in particular reproducibility, because we're currently stuck with algorithms all over the place for which we don't know the code. We cannot replicate. We don't know the population, and that makes the confidence in that very limited.
Yeah, in fact, we know that regulators are pushing back about the use of black box algorithms and computer code where the transparency can be quite opaque. What are the barriers then to be addressed to improving these public-private collaborations, given the fact that we're getting a lot of pushback? Again, is this regulation? Is this just thought leadership through publications, through journal editors? Do you see this as the industry is going to have to step in? How does this work?
Well, confidence cannot be regulated. So regulation can help to create confidence, but it's not enough. So indeed, what we see also among many professionals is skepticism about what they read and whether it will work at all in their particular setting. So that's something that needs to be kept in mind. And there's many solutions for that. One is the sort of guidance that the code gives, for sure. But it's also some of the technologies that BigData Heart and tools that BigData Heart has developed to be able to replicate or to gain precision by combining data from various sources to address heterogeneity and try to explain that. And again, eventually, all of that adds to quality, and quality and reproducibility is something that's going to convince the audience, be it patients or physicians.
Alicia, I'd like to get back to something you were talking about the phenotypic stratification, and you brought oncology into the fold into discussion. Folkert also spoke about the federated nature of the research databases and that you were looking at in the federated research. That works when you have a large N, a large patient population, but when you get into, say, peripheral arterial hypertension, where you have a less than a 1 in a million incidence, that's going to be a very difficult thing when you're going to be searching just for an N of 1 somewhere, and you may be lucky to find that. It's going to be hard to federate an N of 1 with a statistical calculation. How do you balance the need to do federated work, but also to do stratification, as you outlined?
Well, if it's an N of 1, it's very difficult to analyze because that's not very safe and very private for the patients. So,
but you get a good result, I guess. But how do you practically? I mean, in your career, how do you see the balance here? Because obviously, if we have barriers to large data utilization and putting it together, but yet that's the nature of the law right now. How do you balance those demands?
Exactly. Well, first of all, it's very good that there's a very good law for patient privacy. But also it gives us as researchers sometimes a bit more of a difficulty, especially when you're applying for data. It gives a lot more administration that you have to deal with. So I think don't change any of the laws, but definitely try and change some of the administration that's involved with that to make it easier for researchers, because we don't want to know all the private information of patients. We want to do research and want to help you as a patient. And one of the ways to do that is with federated learning, to not share any data between any institutes or countries, and to analyze things in their own center and to leverage that data across those differences different countries. And bringing together data from so many different sources can really add something to that, especially for smaller populations as well.
So Folkert, as a practitioner, how do you see the ability to stratify these populations? Do you see this moving the way of cancer, where we start getting more and more targeted populations with more response ratios, as we saw from Alicia's presentation? Do you see this as an inevitability?
Yeah, but it's difficult because, like in cancer, you can really just having like the genetic expression rate of the tissue at hand, right? So I think it's quite, so they're more advanced, but for a reason, right? So for us, it's more complicated. It's multifactorial, right? The target tissue is not right reachable. So I think with the imaging and the proteomics that I just showed, right? So digital biomarkers, that might, right, we go to that level, but it will never be personalized. It will be stratified medicine or whatever you want to call it. And I just want to just echo also what Alicia said. And another solution is not maybe the federated learning, but also synthetic data sets in the virtual twinning. Right, synthetic data sets, I think in imaging is quite advanced already. And I think we should move that way as well for electronic health record research, because then otherwise it will be difficult, right, to collaborate. I think it's still for CE regulation or FDA that you behind the firewall, you just validate the algorithm, but that you do the development of the modeling right outside the hospital in the public space. Otherwise, it will be difficult.
Yes, and we're already seeing some pushback about some of these things already. It is going to be a challenge. Looking at this in the context of GDPR, there's been a 25% reduction in clinical trials in Europe. Some of those have been cardiovascular related. Do you think we need to look at that, or is it just we're stuck with it and we need to deal with it in the context we have now?
Right. So you see it with the European health data space, you see, of course, the discussion move towards the opt-out as well, right?
Yeah.
I think personally, I think, as Rick mentioned as well, right, trust is not by regulation, right? Trust is a culture and you have to build it, right? So I think everything that we do with the GDPR is so strict. And the question is whether you don't build trust with those regulations, right? I think it's another way. You have to be more transparent. People have to know what happens to their data. I think people are fine that we're using it for research, but they have to know if it's for commercial purposes, for example. So we have to have some guidelines, but I think we need to work towards a different system. I think European health data space is moving towards, right, more like the opt-out kind of mechanism. And I think that's probably, I don't know whether it's the best way, but I think we have to engage with patients and citizens to see indeed whether that's a pursuit something that we need to pursue.
How long did the compliance aspects of getting everyone aligned to work in this federated nature across 8-10 jurisdictions? How long did that take, and how painful was it on a scale of 1 to 10?
So I'll let Alicia answer that.
Alicia, I want to answer.
Alicia, okay, Alicia.
Because she moved from the different sides.
It's difficult. It's
Yeah.
definitely difficult. It really is. But I think we do have a really nice platform right now, and that makes things a lot easier to do it. But it definitely takes a while. But once you have it,
Right.
You can use it for multiple, like answering different questions and using it multiple times. So once it's in place, it's really good.
But the problem is, as a researcher, we do a lot of comparative effectiveness work for industry and government, et cetera. And the problem is, we can make a phone call to Trinetics in the United States and get 100,000 data set like that, in a week, we sign the contract. That's 6 months to 8 months of negotiation on a hospital by hospital basis in Europe. And that does pose a challenge. Do you see that alleviating, Alicia? Do you see things sort of becoming less and less constrained, or are people digging in their heels?
I think it depends. I think it's still it still takes a lot of time, but I think we as a society or as a research society have become a lot better in navigating those waters as well. So that makes things a little bit easier.
That's great. Thank you. We do have just a few minutes left. If any of the folks online would like to submit a question, please click your Q&A button. We're happy to continue talking here. I've got a 1 or 2 more questions, but we'd love to hear from you if you want to submit something. The project's only going to exist for another 7 minutes, so this is your final opportunity to chime in. Comment, criticism, good joke, anything you've got would be fine. Thank you. Okay. If you folks and I'm going to ask each of you individually, if you could clearly articulate one core result of Big Data at Heart, which helps identify a benefit for preventing heart failure, what would it be? What could we implement? And what do you think is the core finding here within the next 12 to 18 months? Folkert, I'll start with you. What do you think is the one key finding from your aspects as a practitioner that you think is a real key deliverable here that can be implemented immediately?
Well, it's difficult because I think the main achievement of the Big Data at Heart is really the tools, right, that we provide, right? So I think if we have these computable guidelines, right, we have this standard definitions, right, within cardiovascular disease, I think that will be a major achievement. And I think a lot of work has been done with the Big Data at Heart.
Alicia, from your perspective, is it the ability to stratify? Is it, finding out that there are other subpopulations that you may not have recognized? What do you think it is?
Well, that's those findings are really, really nice, but I think it's a little bit further away from being implemented straight away. As I said in my talk as well, phenotyping, we're not there yet, not for heart failure with preserved ejection fraction. So I think maybe something else could indeed be like the phenotype algorithms, like the electronic health record algorithms. How do we define diseases is something that we're already using, and I think is a great result from the consortium.
Thank you. And Rick, finally, I guess the last word goes to you here. If you could find one, tangible deliverable, what do you think it is?
Well, what I think is sort of immediately relevant, because we are designing new studies every day, patients every hour, is some of the comparisons that have been made across European countries, but also, for example, between registries and clinical trials. The work that Volker referred to, looking at in- and exclusion criteria for trials and understanding why people have been ignored access to those trials, is something that I'm sure will have very soon consequences in next studies to be designed. At the same time, the comparison that Alicia and others did, comparing heart failure treatment across different European countries, this should trigger those that treat those patients, but also the ones that look into guidelines or practice guidance, to understand some of the differences and understand why perhaps treatment in some regions is suboptimal. So that those, it's a reflection of quality. It's looking into your own work, be it a trialist or a practitioner, and things that I'm sure will help to improve both study design and work in practice. But what I think is perhaps it refers back to what you said about all these difficulties in data sharing and so on. What we have seen is that European investigators, as well as industry, is quite willing to share data and find solutions to some of the regulatory barriers there or legal barriers there. There's a clear interest in combining forces rather than sitting on your own data and have only a limited reach. Combining the force of data, as we've done in BigData Heart, creates an enormous potential. Many things that we haven't done yet, but for which, as Volker said, we have now developed the tools and also the agreements in the understanding of how working with big data across multiple countries, across multiple investigators, across multiple levels of care, how it works.
Well, with that, thank you, Rick. I think that's an excellent summation. All of you should be commended. It's a tremendous amount of output. 100 studies plus that are all very impactful. The presentations and publications in the Lancet certainly are highly, highly respected. Thank you very much for your input and your time. Thank you for our audience. And with that, thank you for the members of Big Data at Heart for allowing us to collaborate with you. And thank you for your time this afternoon. Have a good day, everyone. Bye-bye.
Thank you. Bye-bye. Pleasure.
Bye-bye.